Dr. Ashutosh, and all the participants who are attending today's class. Dear students, today our speaker is Dr. Ashutosh Kumar. His designation, Head of Department, Kailash Deepak Hospital, Delhi. His area of interest is mechanical ventilation, hemodynamic, monitoring, renal replacement therapy, and nutrition. The class is over to you, sir.
Thank you. Good evening, everyone. So today, very important class on cardiopulmonary resuscitation. First of all, we start with some K-type questions. So first question is, during adult cardiopulmonary resuscitation, drugs should be administered by the tracheal route if intravenous access is not immediately available. Blood products can be delivered via the intraosseous routes. In a shockable rhythm, intravenous amiodarone 300 mg should be delivered after the third shock. Correct dose of atropine for treatment of asystole or pulseless electrical activity is 3 mg. During defibrillation, current flow is directly proportional to transthoracic impedance. So please give me true or false type question. So give your response for each option. Anybody? Please give me your response. FTTFF, Saurabh Pradhan. Means you are saying A is wrong. Blood product can be delivered by intraosseous route. Yes. In a shockable after, yes. And the correct dose is 3 mg. No. During defibrillation, directly proportional to transthoracic impedance. Okay. So we should discuss one by one. Some other response also there. FTTFF is the same one. So answer is all right. Basically, drugs should be administered by the tracheal route if intravenous access is not available. So nowadays, tracheal route is not the preferred route for if IV access is not available. The preferred route is intraosseous routes. And by the intraosseous routes, you can give blood product also along with the drugs. In a shockable rhythm, intravenous amiodarone should be delivered after third shock. It's right. Correct dose of atropine. Basically, atropine is not the part of algorithm. So we should not use this atropine. And during defibrillation, current flow is inversely proportional to transthoracic impedance. Okay. So there are only true option B and C, and A, D, and E are wrong. So I think your answer was right. Next question, do not attempt resuscitation, DNAR orders. There are two options for managing a DNAR order perioperatively: to withdraw or keep. If a DNAR order is withdrawn perioperatively, it should be reinstated when the patient returned to ward unless in exceptional circumstances. First time a DNAR decision is considered is often at first contact with the critical care team. If a patient is admitted acutely unwell, a DNAR order should be withheld until the acute event. In an emergency where there is insufficient information and insufficient time to properly assess a patient, default is that cardiopulmonary resuscitation should be started. So what is your take? Basically, when you you have a DNAR order in perioperative period, so there are three methods for the DNR to manage the DNR order perioperatively. You can withdraw, you can keep, or you can modify. So there are not two options, there are three options. Second thing, DNR decisions should be reinstated when the patient returned to the ward unless in exceptional circumstances. And referral to critical care outreach team that result in an end of life decision being made with no admission to critical care are estimated to comprise about 1/3 of all referrals. And if you have not sufficient time to assess the patient, you by default you should start the CPR. So basically option B, C and E are correct. A is wrong because there are 3 options, not 2 options. B is correct. If DNR order withdrawn perioperatively, it should be reinstated when the patient returned to the ward. Third, first time a DNR decision is considered is often at first contact with the critical care team. Perfectly all right. If a patient admitted acutely, another DNR should be withheld until after the acute event. This is wrong. In an emergency, when there is insufficient time or insufficient information to properly assess a patient, the default is that CPR should be started. So if we have not properly assessed the patient because of some insufficient information or insufficient time, we should start the CPR. Second thing, if DNR order is withdrawn perioperatively, it should be reinstated when the patient returned to ward. Okay. And there are 3 options to managing a DNR in perioperative period. You can withdraw it, you can keep it, or you can modify it depending on the situation. Okay. So this is written in the explanation. Next question. Indication for synchronized DC cardioversion include. This is very simple question. I hope you will give response to this question. Sinus tachycardia with syncope, atrial fibrillation with a systolic blood pressure of 75 millimeter of mercury, atrial flutter with ischemic chest pain, pulseless ventricular tachycardia, Mobis type 2 AV block. So what is the answer? It's a true false. You have to give either true or false for every option. So where cardioversion is required? When there is a hemodynamic instability, ongoing chest pain, and third one, altered mental status. So if you find these 3 things, you should cardiovert in arrhythmias. Arrhythmia plus any of the 3, either hemodynamic instability or altered mental status or ongoing chest pain. You should give cardioversion, then pharmacotherapy for managing any arrhythmias. So answer somebody has given TTTFF. Okay. So sinus tachycardia with syncope, no, this is not the answer. Atrial fibrillation with a systolic blood of 70, yes. Atrial flutter with ischemic chest pain, yes. Pulseless VT, you will give unsynchronized. So that's why it's wrong. And Mobis type 2 AV block, you will give some drugs or pacing, but not the cardioversion. So answer is true. True options are B and C. If you have any confusion, you can ask. So answer B and C are correct. So next question. In drowning, protective hypothermia usually occurs. The diving reflex is characterized by apnea, vasoconstriction, and bradycardia. If hypothermic, the arrested drowned patient should be kept cool during resuscitation, as this may improve neurological. 5 rescue breaths should be delivered when commencing cardiopulmonary resuscitation. Immersion time should be considered in decision whether to continue or cease resuscitation. Why not A, as it indicates instability? Okay, I should go back to explain this. Sinus tachycardia with syncope is not for the hemodynamic instability. Okay, so DC cardioversion, synchronized DC cardioversion is arrhythmia plus any of the following. Like which arrhythmias is not, it should not be pulseless VT or VF. For VF or pulseless VT, you need unsynchronized cardioversion, unsynchronized cardioversion or defibrillation. So basically, but for sinus tachycardia with syncope, you need not to go for any cardioversion. That's why A is not true. Okay. So it's not SVT, it's a ST, sinus tachycardia. So next question, in drowning, protective hypothermia usually occurs. Is it right or wrong? Wrong, because it's not always drowning in the cold water. Drowning may be in a normal temperature water. Diving reflex is characterized by apnea, vasoconstriction, and bradycardia. So diving reflex is actually the apnea, vasoconstriction, and bradycardia. So it's true. If hypothermic, the arrested drowned patient should be kept cool during resuscitation, as this may improve neurological outcome. This is not true. We should not keep cool already if patient is hypothermic. 5 rescue breaths should be delivered when commencing CPR. So in drowning, this is very important to understand that the old dictum of ABC should be keep in drowning: airway, breathing, and circulation. Normally nowadays CAB, compression, then airway, then breathing. So, but in drowning, airway has priority over the compression because it's a respiratory arrest. That's why we should give 5 rescue breaths initially when you start CPR in drowning patient. So you should remember this important point. There is only one situation where you don't follow CAB. You have to follow ABC in drowning. Emergent time should be considered the decision whether to continue or cease resuscitation. Obviously, if emergent time is more than 10 minutes, it's a poor prognostic marker. So that's why true answer is B, D, and E. So submersion in icy water may lead to protective hypothermia, but this is not common. Diving reflex, obviously because of ophthalmic division of trigeminal nerve and its apnea, vasoconstriction, and bradycardia. Attempt should be made to raise the body temperature of hypothermic patient. You need not to keep cold during the resuscitation. 5 rescue breaths should be delivered when commencing CPR in drowning patients, and in emergent time more than 10 minutes indicates prolonged asphyxia. So that's why option B, D, and E are correct. This is a very important question. Sometimes they ask a long question in EDIC 2 of drowning and arrest, cardiac arrest. So you should know exactly what is drowning and all the nitty-gritties of drowning, hypothermia. So they are very fond of asking the question, a patient drowns in a cold water, icy cold water, and then patient has cardiac arrest, and emergency team rescues the patient, and then what will you do for the resuscitation purpose and for the managing the temperature because patient is hypothermic. So you should know all these things, how we approach CPR in a drowning patient, how we manage the temperature of a hypothermic drowned patient. So we should know all these things. So this is a very favorite topic in EDIC 1, EDIC 2. Then donation after cardiac death, DCD. Functional warm ischemic time begins at asystole and ends with cold perfusion. Decision to withdraw cardiorespiratory support should always be independent and made before any consideration of DCD organ donation. CPR is an acceptable intervention to maintain life while the retrieval team is being mobilized. It is acceptable for the donor transplant coordinator to care for the potential donor while they are still alive. Kidneys retrieved from DCD donors have worse long-term outcome compared to those from DBD donors. So basically, there are 2 types of donors. One is DBD donors, donation after brain death, and donation after cardiac death. So this is a difference. Nowadays, because of less number of accidents and road traffic accidents, DVD donors number are getting decreased and DCD donors numbers are increasing. So we should know what is DCD donors. So basically there is a functional warm ischemia time which begins with the first hypotension. So it starts when the systolic blood pressure decreases below 50 millimeter of mercury or arterial oxygen saturation SpO2 below 70%. And it ends with the cold perfusion of the organ. So this is known as functional warm ischemic time. It starts when the hypotension or desaturation occurs, like systolic should be less than 50 and SpO2 should be less than 70%, and ends with the cold perfusion of the organ. So we should know the maximum functional warm ischemic time for different organs. Like for kidney, it is a 120 minutes. And for liver, it's a 20 to 30 minutes. For lungs, it is a 60 minutes. For pancreas, it's a 30 minutes. Outcome following DCD liver transplantation are acceptable, but greater postoperative morbidity, higher incidence of graft failure and biliary complication compared to liver donated after brain death. So first option was false, that functional warm ischemic time begins at asystole, not asystole, first hypotension or first desaturation. It starts from that point. So you should calculate the warm ischemia time from that point of time when first hypotension or desaturation occurs. Second option, decision to withdraw respiratory support should always be independent and made before any consideration for organ donation. So there should be not any conflict of interest or any biasing when you take a decision to withdraw cardiorespiratory support. And it should not be because of organ donation. It should be on and on, and organ donation decision should be later on. CPR is an unacceptable intervention in a potential DCD donor if cardiac arrest occurs prior to retrieval team being ready. It is unacceptable for the donor coordination to care for the potential donor while they are still alive, because this is a conflict of interest. So that's why it's also false. So only true is option B. The decision to withdraw cardiorespiratory support should always be independent and made before any consideration of DCD organ donation. Okay. So you should know what are the Maastricht classification of the DCD, what are the 5 categories, and what is the difference between DVD and DCD. And you should read the very important topic, care of the organ donor. So hormonal therapy in the form of thyroid hormone or vasopressin or steroid for the care of potential organ donor. So you should read these very important topic. Somebody asked what option E, kidneys retrieved from DCD donors have worse long-term outcome compared to those from DVD. Outcome will be same from DCD or DVD donor. There is no difference in kidneys retrieved from either DCD donor or DVD donor. Okay. Next question. During adult cardiopulmonary resuscitation, current UK resuscitation and related guidelines recommend that adrenaline should be given before the third shock in shockable rhythm. Chest compressions should continue during charging of defibrillator. Hypotension is a reversible cause of a cardiac arrest. There is no indication for the 3-shock strategy. Following unsuccessful resuscitation, the patient should be observed for a minimum of 5 minutes before confirming death. Tell me. So option A, adrenaline should be given before the third shock or after the third shock. It should be given after the third shock. Second option, advanced lifestyle guidelines state that every 5 seconds increases the pre-shock pause almost half the chances of successful defibrillation.